Now over to Professor Sanjay Kumar, sir. Please come.
So, good evening. I first of all, I want to thank Alok for giving me opportunity to talk on this topic, current status of transcatheter valve replacement, and I thank him again for giving me this cardiology topic. It doesn't have. I'm going to. No, I'm not going to. I'm not going to say anything about surgery versus. Okay, yeah, that's fine. So I'm going to say all good thing about this, and let's see what we have. So, just at the outset, I want to say that transcatheter valve replacement has fundamentally reshaped the treatment paradigm of valvular heart disease, providing a less invasive option that has saved countless lives and improved quality of life for patients worldwide. It is nice to see all over the means when you look at the internet and various social media site, the patients giving testimonial about how they benefited, especially those elderly patient, frail patient, and who were not a candidate for operative intervention. So, since it is about all the valves, we have because this transcatheter approach has touched this modality has touched treatment for all the valves: aortic valve, which is transcatheter, also the balloon valvotomy, mitral valve, balloon valvotomy, mitral clip, and mitral valve replacement, pulmonary valve, percutaneous, this valve replacement, and balloon valvotomy. Tricuspid is tricuspid valve replacement using the percutaneous catheter based technique. So we will discuss this under this heading. I'll try to cover as much as possible. Predominantly focus will be on the TAVI, the transcatheter aortic valve replacement, and that is the one which is the main topic. However, it is being used for other valves as well now. So these procedures have evolved from experimental intervention to reach a standard care. And this genesis started way back in late 20th century when Anderson first did percutaneous valve implantation in animal models in 1992, and subsequently it has reached the standard care driven by varied device improvements, rigorous clinical evidence, evolving guidelines that prioritize patient-centered outcome. So over the last 20 years, the journey of the TAVI. So its first implantation was done in 2002, and subsequently the trials has started from 2010 onwards. So earlier it was designed for the extremely high risk patients who were not a candidate for surgery. And then the trial was extrapolated for high risk patient, then intermediate risk patient, low risk patients, and it has reached a stage now that in 2020 it has found its place as a modality of treatment in the ACC AHA valvular guideline management and also in the European guideline. So it has evolved from inoperable and extreme high risk patient indication to first line treatment in low risk patients who are more than 75-year-old patients. So as I said, the 2002 was the first implantation was done by Crevier. It was done for the severe calcific aortic stenosis. The earlier techniques were actually what little cumbersome because obviously, as you understand, it was the beginning. So vascular complications, prolonged TAVI procedure, also the hospital stay were prolonged. Following these procedures, the risk that is calculated is based on the STS scoring. So that is, if it is more than 8%, it is high risk. If it is less than 4%, it is the low risk. Euroscore is the another scoring system we surgeons use commonly, but it is not really beneficial in doing this risk stratification for this patient for TAVI. So indications for TAVI. What do the latest international guidelines recommend? So if you really see now, this for the patient with this was Dr. Jan had already gone through these guidelines. So severe aortic stenosis now in the high risk and also in low risk patient, with the elderly patient which have got a lesser life expectancy. Now the TAVI has found its place as a class 1 indication. And similarly, you can see in this patient with severe aortic stenosis, SAVR, wherever there is SAVR indicated in those patients, the TAVI is indicated as well. So that's like almost like a class 1 indication. So class 1 indication, you can see the first 3 indication, class 1 indication with level of evidence A in asymptomatic patient with any A's and with severe AS and high or prohibitive surgical risk. So TAVR is recommended. Similarly, patient with severe AS who are more than 80 years of age or younger patient with a life expectancy which is less than 10 years. For symptomatic patient with severe AS who are 65 to 80 years of age and no anatomic contraindication to transfemoral access. So these are the patients. This is the anatomy we really look for, means in detail when we do the TAVI implantation. So detailed analysis by the heart team that is done to assess the root of the aorta and also the sinotubular junction in these areas. Various measurements are taken. European guidelines, that is the latest one, it has also included one essential criteria that favors TAVI, and that is the frailty index. So you can see that severe frailty, one of those which is forms in the category where the patient, this surgery is not favored, there the patients are benefited with the TAVI. So this is the clinical frailty scaling system. So that is done for these patients who undergo TAVR, and they found that the patient who have a frailty index, poor index, less of them are offered TAVI, but still they benefit with the TAVI. This is the scaling system. Geriatric people use it for their practice. These are the 2 valves that is commonly used, Edward valve, and this is the core valve, and one is the self-expanding. These are the valves which are nitinol based, and otherwise stainless steel or cobalt chromium valves, they are balloon expandable valves. Medtronic valves, these are this porcine pericardial valve. You can see that self-expanding, nitinol supported. Sapien valve, these are the balloon expandable valve, which is again, this is cobalt chromium frame. My valve, this is indigenously developed valve. This is one of the company which is based in Gujarat. They have designed. We use their prosthetic valves also. So they have also used this is called my valve. So this is the local, means Indian made valve. So these are various studies that it is summarized here. It is a busy slide. You can't see very well, but they are done for all those 3 studies for the extreme high risk inoperable patients, high risk patients, then intermediate risk patient, low risk patients. So to summarize existing evidence, the partner A and B, the partner 1B and core valve trial, which was done for the extremely high risk patient, and there they found that the TAVI was superior to the medical treatment. Partner 1A and core valve HR, that was done for the high risk patient, and the TAVI non-inferior or superior to the surgical valve replacement. Intermediate risk partner 2A and TAVI. So TAVI was non-inferior or superior to SAVR, surgical. And low risk patients, then there is a NOSEN trial, part 3, Evolute LR trial. These are some of the trials are still ongoing. So TAVI is non-inferior or superior to surgical valve replacement. So expanding indication. Now TAVR is being also offered to the younger patients, and bicuspid aortic valve, which was earlier found to be not a suitable candidate for TAVI, now they are doing for this bicuspid aortic valve as well, and also the patient who are regurgitant valve. aortic regurgitation. So expansion of indication, you can see the younger patients, bicuspid aortic valve, asymptomatic severe aortic stenosis and aortic regurgitation. So these are various trials they are involved, which is at the bottom listed there. So for this bicuspid aortic valve, again, because there is associated aortopathy and asymmetrical cusp size, that makes it difficult. So that's why they use the self-expanding valve, which is better adaptation to the irregularly shaped landing zone of bicuspid aortic valve. So this another study which was out for the predominantly for the bicuspid valve and tricuspid valve comparative study. This is the study where there is a patient specific computer simulation. This is the technology they used for guiding the transcatheter treatment for patient with bicuspid aortic valve. TAVI in aortic regurgitation. Earlier, it was not recommended. It had poor results. However, now it is being used, and there are certain studies they are involved, larger series, which is for the pure aortic regurgitation. So you can look at the results of them. These are the various valves which are used for patients who have a native aortic valve regurgitation. These are the balloon expandable, majority of them are self-expandable valve that is in the various companies made. Anticoagulation following this, there has been evaluation that they don't use the oral anticoagulation, they use the single antiplatelet is good enough if the patient doesn't require DAPT or if it is a high risk surgical patient, high risk patient for bleeding. So new advances, other advances that has taken place in TAVI is the valve in valve. So it is started with a core valve in 2007, but again it is a multidisciplinary team approach because because the moment you put another TAVI in a TAVI valve in valve, these are the problem you have is they are always a lesser effective orifice area. So this is the valve in valve data versus the repeat surgical aortic valve replacement in patient with the failed aortic bioprosthesis. So this is another area which is going to be a big problem. If it is being offered to younger patients, and because we know that because they have a longer life span, and moreover, that valve is not going to last. Invariably, it's going to degenerate. So in that case, they will always require a redo of procedure. So when these transcatheter valve fail, they require nothing less than the surgery, and the surgery can be very difficult in these patients. So you will see very soon there will be a large number of these patients who will be coming to the surgeons for operation, and they will require maybe aortic root replacement to change the valve. So there is a now redo tower registry that is being maintained for this purpose. Now I will just rush through these transcatheter other valves. So transcatheter mitral valve interventions. So pure MR, you have again this is the guideline which says that for primary mitral regurgitation, and when you look at the secondary mitral regurgitation, the transcatheter edge to edge mitral valve repair, which is also called it's like an Alfieri technique, which is mitral clip is used by cardiologists to in the same principle. So these are the various method that is used for patient with the MR. So leaflet or caudal procedures which are done with these techniques. Then there is an indirect annuloplasty that is done with this technique. If there is a direct or left ventricular annuloplasty, so that is also these devices are available. Hybrid surgical procedure, left ventricular remodeling, and transcatheter mitral valve replacements. So mitral clip, this is the mitral clip. You can see there are two clips that is used to approximate those anti and posterior mitral leaflet, it creates the double orifice and reduces the severity of the mitral regurgitation. So Everest trial, which was a feasibility and safety trial, it showed that the percutaneous repair with mitral clip system can be accomplished with low rates of morbidity and mortality with accurate MR reduction. So I will just rush through these slides basically. So that is Everest 2 trial. COAP trial was done for mitral valve repair again. So MTR is that this is edge to edge repair, transcatheter edge to edge repair, mitral clip. And this is the various valves which is used for the transcatheter mitral valve replacement. Other percutaneous techniques are coronary sinus annuloplasty, mitral annuloplasty, hybrid ring annuloplasty, as I said, and percutaneous caudal implantation. Percutaneous pulmonary valve replacement. It is utilized because till now the surgery was the mainstay of treatment for this pulmonary valve replacement, but now this catheter-based technique using the Melody transcatheter pulmonary valve is being very commonly used, and it has established itself as a modality of treatment. So this is transcatheter versus surgical pulmonary valve replacement systemic review. Then transcatheter tricuspid valve interventions. It is already has been discussed in the guideline by Dr. Jan. So I will just go through that. So TTVI, this is the valve replacement. There are various valves that is being used for. They also use the annuloplasty device and the valve implantation. If so, it may be a direct suture annuloplasty or direct ring annuloplasty, coaptation enhancement, or it can be valve replacement. If you are not able to replace the valve, then in that case, what they do, they put the SVC and IVC cable implantation. So that's called trick valve. So this is the various valve again. So again, just to summarize again, whether it is just a technology-driven gimmick or it has its future. There is a multidisciplinary team that has to be involved, and hard team approach, that is the one which gives you the best decision-making process in order to decide what is the right for the patients. The patient goes through a referral system. Only those patients who are confirmed as a candidate for TAVR, they are evaluated further and they are subjected for TAVR. So I would like to conclude in the end that we have transcatheter aortic valve replacement primarily is a established modality of treatment, but transcatheter mitral, tricuspid, pulmonary valve replacement is also being commonly used, and now it has become evolved from the compassionate to a ubiquitous therapy.
Can you conclude, sir?
Yeah, I would just conclude in the end. There is a recent advances and challenges that looks like that in the future it's going to have AI stimulation by resorbable valves. The challenges that remains is the structural valve degeneration and thrombosis that needs to be addressed. In the future, robotic transcatheter valve replacement, regenerative tissues we're using for this valve leaflets. And the trial result of the early TAVR for asymptomatic patients, they are the one which will be the game changer. So post TAVR, if the patient gives you a slogan that I could hike again, life restored, that's what we want to hear from these patients. So heart team integrates frailty indices and sarcopenia assessment and multi-parametric CT, which is shared decision tools project to 10-year valve longevity. So the heart team approach is the key to provide the excellent outcome of the transcatheter valve replacement. With that, I would conclude my talk. Thank you.
Excellent talk by Professor Sanjay Kumar, sir.